triggered the initial phase. There's this mild hyperthyroidism, right? And that's due to that passive release of stored hormones, followed by a very brief euthyroid. You think I'm going to test you or give you a euthyroid situation? I'm not. Then you have your hyper, transitioning into hypo, right? So just understanding that and how that's different than Graves. There's the autoimmune versus the viral painful subacute, where the infectious bacteria present very differently. You guys see that now, right? So with our viral, that's probably the one that is the most hyperthyroid as far as like presentation, where you might be like, ooh, does this person have Graves? But remember, they're different. They have a painful thyroid. Does Graves have a painful thyroid? No, right? But they're painful. They might have radiating pain to their ears. They may or may not tell you if they recently had a cold. And then if you look at their labs, their CBC might be off, but really the ESR is going to be elevated. And that T3 might be high, but not crazy high like it is in Graves, right? So there's differences there. And then, of course, if you're still not sure, you could do that radioactive scan, and that is the example of thyroiditis, the viral subacute, where you'll have little to no uptake, right? Because that virus is disrupting the follicular cell process. And then what happens with the virus? What does our body do? Fights it, right? It's a self-limiting thing. And so over time, follicular cells come back to normal function, but it takes a while, right? So that's why we have that hypothyroid state for a few months. The treatment for a subacute is very different than the others, right? How do we treat it? It's a viral trigger. What do we do with the virus? Supportive care. Okay, so NSAIDs, steroids if NSAIDs aren't working or if it's really severe, and maybe some propranolol because that's the one that has the most kind of hyperthyroid state. Which one of these ones is usually permanent? Hashimoto's postpartum, painless, painful, or infectious? Hashimoto's, right? In that case, the infiltration is autoimmune, and we have thyroid follicular cell destruction. And so then those people, it's usually, vast majority, it's lifelong blood treatment. In all of these cases, are they going to typically come in the hyper state or the hypo state? Typically hypo, but be ready, you know, when there is that hyper state, especially postpartum and that painful subacute. Infectious, how is that different? It's really, really different, right? No other situation do you get a red, fluctuant, painful, high fever, leukocytosis, high ASR than that one, right? How do we treat that? Bad bacterial one. Yeah, antibiotics. We're not doing it right there. It's inpatient. And then of course the IgG related one that I should care about, but I don't so much. That's your grandma one that I don't talk about. I didn't really go into the treatment or really anything intentionally. Okay. All right. Any questions on thyroiditis recap? Feeling good about it? All right. I'm going to go talk about goiters, nodules, cancers, and emergencies today. And then we'll wrap up thyroid completely before lunch. So, what's a goiter? Yeah, it's enlarged. Are we scared of them? Maybe, I don't know. Yeah, so we're going to talk about what usually causes them and what we do with that in clinic. Because you will see these in clinic. Is anybody here like a little nervous, like think the thyroid exam is kind of a elusive thing that like, am I actually going to feel a nodule or a goiter? The more you practice, the better it is. In PA school, the girl, my friend who sat next to me, she had a goiter. And I was like, okay, I probably will never see another one again. But at least I know what abnormal looks like. But you will in clinic, the more you examine and the more you practice. But again, it's enlargement of the thyroid gland. It can be diffuse or nodule. The most common cause is iron deficiency. Are we iron deficient here in the United States? Or iodine deficiency. Are we iodine deficient here in the United States? Not so much, right? Our causes are going to be that hypo or hyper. It's hyper because of the autoimmune activity causes increased production and synthesis and then growth of the thyroid gland. Or hypo, our gland can't keep up, but TSH is stimulating, right, it to work from the anterior pituitary, and that stimulation can, for some people, cause the thyroid to get enlarged, okay? And then obviously pregnancy makes sense in meds. So how many people do you think are affected by iodine deficiency in the world?
A lot.
A lot, yeah, 1.9 billion. That's a lot. What's the population roughly of all? Anyone know? I didn't know. What do you know?
7 billion?
7, it was close. I googled it. It's 8.2 billion. So 1.9 out of 8.2, that's a significant amount. And then we get patients from all over the world, right? So again, just to kind of put it in perspective. Could you spot this goiter? I kept this up here. It's not super obvious, and because it's not super obvious, right? So you would need to feel this patient to really know, but it's probably a little bit enlarged on the right. What about this one? The shadowing is a little annoying, but you can see there it's enlarged there, yeah? Of course, we'd still palpate it because it could be nodular or firm. This one, right or left side, is enlarged, do you think?
Left.
Yeah, right? And then maybe both, right? But you can also adjust the patient potentially too. And then there's this gentleman, I mean.
The left side?
Yeah. That one we'll talk about briefly, but rare in the United States. And I'll talk to you about the pathophysiology with that in just a second. Okay, so with iodine deficiency, we have low iodine. So we need iodine to synthesize T4 and T3. So the thyroid needs that for function. And so what will happen with these patients is their thyroid can't keep up. So what does TSH do? What does the anterior pituitary do with TSH? Cases up, right? So the excess TSH will, over time, these kids, typically kids, will have a goiter. Now, if you leave that untreated for a long period of time, it gets bigger, and it can become nodular. And then, when it becomes nodular, sometimes it kind of gets a mind of its own, and that's what happens with this guy. It becomes nodular, and because of the receptor activity, each nodule is kind of like proliferating and doing its own thing. And so you get cystic nodules, hemorrhages, all sorts of stuff, and then just intensifies the hyperthyroid state. So that's this guy. Ultrasound makes sense. You could do that to evaluate it further. And then, of course, we need labs before that, right? What are our labs that we're going to do when we have a goiter? TSH for sure, and then let's start at T3, T4 at the minimum, or T3, right? You can do autoantibodies. If those are abnormal, ultrasound it, and then give them blood thinners. These are the areas where you might run into this, or people who are from these areas. So we're going to catch this on exam or incidentally with imaging. And again, we can't just ignore it. We need labs, potentially imaging, and then treatment. Obviously, if they have hypo or hyper, we're going to manage that. A lot of patients, not all, but the goiter will improve once we treat it. If you have a patient who you get TSH on and it's normal, and they're not having any restrictive symptoms, they feel fine, you can also just monitor that, okay? We need to educate them on hypo and hyper symptoms, okay? A lot of this we're going to talk about just kind of like brings it all together specifically in the goiter topic. Now, goiters can be multinodule, and the toxic multinodule goiter, just its name, it tells you that things aren't going really well, right? This is typically an older patient, over 50, and they have a history of these multinodule goiters already that weren't causing a problem, but then they do. And they cause that hyperthyroid state, right? Remember, all these nodules are doing what they want to do, and they cause this hyperthyroid state. Definitely palpable. You're going to have hyperthyroid symptoms. The lab makes sense. Diffuse patchy uptake will look like this. That's what it looks like when it's surgically removed. So if I have a patient with all these toxic multinodule goiters producing excess T4 and T3, I'm in a hyperthyroid state, how should I treat this patient? do. Not the guy with all the things, but maybe like, I'm uncomfortable with it, I don't like the way it looks.
Surgery.
Yeah, what did we thinking?
Surgery.
Surgery, all right, I like it, exactly. So first, we're gonna do meds, control this propanolol. Does that do anything for the hypothyroid state? It doesn't. We give it for the hypothyroid state. We can do some anti-thyroid meds, but it's not gonna shrink the goiter, okay? So it's really just kind of like a Band-Aid effect, based on the recurrence and just kind of the lack of improvement of like the cosmetic improvement. So current says surgery is definitive, right? We're going to do a total or near total thyroidectomy. So we're going to take this bad boy out. Especially with patients who it's causing irritation. As that gets bigger, it's going to be harder to swallow, maybe harder to turn my neck, radiating pain to my ears. Or I just don't like the way it looks. I have a bunch of these big cysts on my neck and I'm sick of covering them up, right? So that's a good surgical candidate. Now, surgery is the definitive, but technically the radioactive iodine-131 ablation is also definitive, but that's going to be for your elderly patient that has like congestive heart failure. They don't have any compressive symptoms, but there's a lot of risk for them to go under the knife. Okay, so that's why technically there's two definitive treatments, but you use the patient standard to decide which one. Does that make sense? So how do we treat toxic multinodule goiters? Surgery, right? Unless they're a little, or it's usually a female, but it could be male, a little old patient who has congestive heart failure, lots of surgical risks, then we might try ablation first. Especially if they don't have any compressive symptoms. Questions on goiters? That was real quick, pretty straightforward. So, thyroid nodules is, I feel like you're going to see it a lot, but it's one of those, to me, in clinic, is always annoying because I can treat hypothyroidism, hyper, no problem. But with nodules, I'm like, crap, what do I do? What's the size different? Like, so this is one of the things where I saved a favorite. It was on my computer, just like a flow chart. When you find a nodule, what do I do? So when in clinic, there are resources where maybe you're smarter than me, and you can remember this, no problem. But if you can't, there's resources that you can use. Yes?
So you found the toxic multinodal goiter. Like what surgical specialty, like the analysis is like ENT?
Yeah, ENT. So like endo will probably potentially be involved, and probably put both, but ENT would be the one that do surgery. And like when we get to FIAs, it's endo. It's like all the specialists are in there for that ENT. I put in both referrals though. That's a really good question. And then we can give them propanolol until they get some. Or maybe some antithyroid meds. Okay, so thyroid nodules are very common. Honestly, I feel like incidentally find by imaging is the most common. Women's health nurse practitioners are really good at finding these, probably because that patient population really only goes in to get their pap smear, so they're catching it more than say just like a primary care provider. Most commonly in women, go figure, just like most of these thyroid diseases, and regardless of if you feel it and they're like, oh, it's not causing any issues, you can't ignore it. You need to evaluate any thyroid nodule further. It can be single, multiple, non-palpable, and then of course, all those can be benign or malignant. We'll talk about each thing. Single nodule most common, and thank goodness the vast majority of these are benign. They can be cysts or just a regular benign thyroid nodule. How do you think we would determine if it's benign or malignant, primary, metastatic?
Biopsy.
Yeah, biopsy. What's the fancy biopsy we use? FNA, needle biopsy. Yeah, exactly. Then multiple nodules, especially when I did my endo rotation in school, I saw a lot of patients with multiple nodules, and you just look at them, I didn't feel any of them, but then under ultrasound, they were in there. And so again, multiple nodules are a possibility too. Don't memorize this list, just know multiple single, okay? And then just the conditions of days. This totally makes sense, right? Non-palpable nodules found incidentally by imaging. So maybe they're getting imaging for some other reason, you might catch it. Now, if someone does a CT of the neck for something else, you need to do a thyroid ultrasound of that incidentally find nodule. Okay, so ultrasound for thyroid is still like the main go-to for thyroid nodule imaging. Okay, and again, most of these are benign. Just kind of like going farther into the benign stuff, right? You could have a goiter and a benign nodule. They're usually soft and mobile, so they're not like fixed to the skin, and you're not having surrounding lymphadenopathy. So if I have a fixed nodule, then they have a like lymphadenopathy, that's a little scary, right? They have a history of like radiation, that's a little bit scary. Most of the patients who have thyroid cancer don't have a really pertinent hospital history, though, at least from what I've seen. And just like goiters, they can potentially regress. But our benign, malignant nodules, if you have a young male with a thyroid nodule, that should spark alarm, right? Because most of these thyroid conditions are women. But if I have a young male with a nodule, I get worried. And the first goiter I saw on my own was a young active duty male. Luckily, it was just a goiter and not cancer, but I definitely was like, oh, what did I was excited. And then again, they might have a significant history that's suspicious, but I feel like most of my patients haven't. But we still ask those questions. We'll talk more about medullary thyroid cancer, but that definitely increases the risk. A family history of that increases your risk. And then as those nodules cause problems, as a malignant nodule increases in size and causes havoc, they might complain of dysphagia, dysphonia, even and other things like that. This is a table from Current. You don't need to memorize, but it kind of like tells you low index versus high index of suspicions as far as like hot versus cold lesion, ultrasound findings, a young male versus an older female, things like that. Just highlights it if you're curious. Okay, so we have a 39-year-old female who has a thyroid nodule. What do we do first with that? We're going to start with labs. You guys know this, TSH all day. I throw in a free T4 too. But I'm going to start with TSH. Now, if that TSH is low, what does that indicate? Hyper or hypo? TSH is low. Hyper, right? So I'm going to have to do two things. I have to do an ultrasound and a radioactive iodine 123 scan. So I'm doing the radioactive scan and an ultrasound. Okay. Now, if that TSH is normal and they don't have a thyroid disease, or it's high and they have hypothyroid disease, all I need is an ultrasound. Okay. And this is that table if I get right in your face. Shiver. Okay. Now, I get the ultrasound, and that's going to help guide me to, do I need to do further? Is this abnormal? Is this concern for metastatic or cancer or not? Ultrasounds are super easy. I already told you I order these way more than I do the scans because I see hypo way more than I see hyper. And so will you. So understand this pathway, okay? All right, so we get the ultrasound, and you can see, so the top one is a cyst, and this bottom one is not so good. So it has some darkening here, and then we have this irregular, so it's solid, and then like inside it looks cystic, so that's concerning. But yes, as much fun as ultrasounds are in clinic, I don't expect you to read them in here, and we have the radiologist read them, and so they're going to tell us if there's anything suspicious. This list should make sense, right? A complex cyst, microcalcification, irregular border, or bigger than a centimeter. Like, these are all suspicious findings. Okay. On a test, if I want to make sure you guys get that this is suspicious, I should probably say more than just like I don't know, microcalcifications, right? I'm going to really try to paint that picture. And then the heterogeneous nodule is more this example where you have that's what that it looks like to me. They're calling it heterogeneous nodule. But again, it's big. It's over a centimeter. Is there space for things over a centimeter in here? Not so much. So So we need to evaluate it, and you know this. We evaluate it by a biopsy, specifically a fine needle aspiration biopsy, FNAB. That tells me, is this benign or malignant? And this just like reiterates things that are suspicious. So like if the nodule is over 2 centimeters but looks totally benign, biopsy it. If they have a history of radiation and it's small, biopsy it. So it's not always clear cut. But guess who helps you? Your lovely radiologist. They will help you. And then when it's benign, they'll be like, hey, looks benign. Follow-up ultrasound in 2 years. Follow-up ultrasound and never. But they'll say that, but then what do you still need to verify and do your little flow chart and make sure that that is correct, okay? Because you ultimately own that patient. Does that make sense? This, so when we get the biopsy results, they, obviously there's just like a range of how they grade the pathology. Don't memorize this, but essentially they follow a format based on various things, from appearance to cell findings. And then again, this tells us that kind of this is essentially the grading of the malignancy. Don't memorize this, just know that this is what's happening when you send someone to get an FNAB. I actually had a patient, I saw a virtual clinic last month, and she had a nodule and it changed a lot. It was suspicious to me. It checked some boxes on here, it checked some boxes on here, and so I had to send her to get the biopsy. All right, so treatment, benign, I already said this, regular ultrasounds, right? There follows a guide on that. And then obviously if that, with the patient I had, her normal benign nodule changed significantly, so we ordered the FNAB. If it's cancer, surgery should make sense, right? We want to take that out. And we'll talk about the treatment in the individual cancers in just a minute. But surgical is the treatment for those. And then if I'm taking out either the full thyroid or part of the thyroid, what does that patient now get? Levothyroxine, right? And again, these are the patients you're going to see with this nice, pretty horizontal scar on their anterior neck. Typically women, or again, a young male who had a nodule of those. Okay. So there's 4 types of cancer, and papillary is the most common, and luckily it's the least aggressive. So when you have people with thyroid cancer, they usually, majority do really well. They have the thyroidectomy. Many may not even need chemotherapy or anything like that, depending on how it's spread. But nobody wants cancer. But if you have this one, usually, especially if it's papillary, patients do really well if it's caught early. Okay, and then there's less common are the ones below, with anaplastic being the most aggressive. There's a term I added this because you might see it in like radiologist reports, but it's not on the test. When they say differentiated thyroid cancer, that means the papillary follicular, and that has to go with treatment in the future slides. So I just added it for terminology, but not for the test. All right, so papillary, you will see this. It's the most frequent, most common that you have. Obviously, the exposure to radiation makes sense, but a lot of people don't have that history. They still get these papillary thyroid cancer, but they do really well. 98% have a 10-year survival rate. That's pretty great. Follicular, a lot less common than 11%. It absorbs iodine, and so does papillary thyroid cancer. Why is that a good thing, that these 2 cancers absorb iodine? How can I use that? I already told you I'm going to probably surgically remove this cancer, but how could I use that? Yeah, we could do ablation too, just in case, like I'm doing surgical removal, but I'll show you. Oh wait, I already showed you the picture of the surgery, how like, it's all just, it's not a pretty picture of pink tissue with white tissue. No, it's all, and so the ablation can help after you have the surgery. Some, depending on the year and the recommendation of the source, they may recommend ablation after, and you can use that for follicular and papillary. This one's more common to metastasize, and if it does, it goes to those areas. Don't memorize that, okay? Which is this more likely to mets. They still do pretty well, but again, it's more aggressive than papillary. Medullary thyroid cancer. Have you guys heard of this? It's definitely like with GLP-1s, right? You can't give the GLP-1s to someone who has pancreatitis or medullary thyroid cancer. This is medullary thyroid cancer. It's not super common. It is associated with multiple endocrine neoplasia, which will be a topic we talk about at the end, specifically 2 of those. It does not absorb iodine, neither does the last one, so we don't have the ablation. This mets pretty, it'll spread, metastasize easily, and based on the pathophys on this, a lot of times you'll catch it when they have they'll have like diarrhea, flushing, and that's just due to like calcitonin and other things that are released. Again, don't memorize this, just understand it exists and how medullary thyroid cancer correlates with MEN in our last lecture. It'll come together. And then luckily the least common and most aggressive are the same. And this is older patients, and they don't do so well. 10% have a 1-year survival rate versus 5% have a 5-year. So not great, but again, I've never seen it. I hope I don't, but it's super, super rare. Signs and symptoms, I'm not gonna really dive in on this, just should make sense, right? You have a nodule that's growing, it's not benign, it's causing discomfort, or the patient doesn't even know, right? But we're gonna do our labs, we're gonna do our ultrasound, and then the FNA biopsy and get them to the diagnosis. This we all know. Don't worry, put FYI about thyroglobin and calcitonin. Just need you guys to know that. I don't have a question on this, but it's just that you're going to use that bubble chart because that correlates, that's a nodule and that correlates to cancer. But thyroglobin is essentially, it's a precursor to T3 and T4. So when it's elevated, it can be elevated in some cancers. You don't need, that's like in weeks. This makes sense. What are we doing? We're ultrasounding it, right? Yep. We're ultrasounding it. And we're not just ultrasound, but also with the neck ultrasound, we can see if there's any detection of mets. But we need to do like a CT, a PET scan, maybe an MRI. So we're not, once we know they have cancer, the oncologist is probably going to do a lot more imaging. Okay. And then treatment of tracer surgery for all thyroid cancers. And then papillary and follicular, we can potentially add the radiation because they absorb iodine. Any questions on that? Well, kind of fast, I think you kind of like see what I care about and what I don't. Talks about that. It destroys the remaining thyroid tissue with the ablation and potentially can decrease reoccurrence rates because these guys have to be followed quite closely. So you have a patient, they had papillary thyroid cancer, it didn't mets, they did surgery, maybe they did ablation or maybe not. Now what does the endocrinologist do? ENT did the surgery, everything is good. What does endo do? Took away their thyroid. Yeah, levothyroxine. But the big thing with this is that they really suppress thyroid function. So you are TSH. So they really suppress TSH. And how long they do this varies on how aggressive the cancer is. So you're going to see a patient who just had papillary thyroid cancer with a really, really low TSH, and that's intentional. Okay, so these people are managed by endo for like at least 5 years. And if I'm suppressing their TSH so much, almost to like a borderline hyperthyroid, then usually you are going to need a DEXA scan on these patients and things like that sooner. Okay, but again, it's just trying to suppress activity post-cancer treatment. Okay. Questions? Does that make sense? Say the level and like duration is based on risk. Okay, that's it for nodules. I started at 10, right? Okay, so we're just cruising. We'll go into emergencies and probably gonna get done early because I only have a few slides and I don't have with what's next, and then we'll go through the clinical pieces. So if you want to tell whoever, what do you say next?
Ortho.
Okay. All right. I saw that. What is here? All right. Thyroid emergencies. This is kind of not fun for the patient, but it breaks it up a little bit, right? Okay. So the first thing, if I say, is thyroid storm. What do you think that is? Hyper or hypo?
Hyper.
Hyper, right? We have a storm of ruin. There's lots of too much of a good thing. Too much T4 and T3. So extreme hyperthyroidism or thyrotoxicosis, right? Thankfully it's rare. Has a high mortality rate, and it's often seen with Graves. There's various precipitating factors. Amiodarone is one of those. I like the range, 3 to 20% with study. But a stress. So if you have stress, like you were in a car accident, or you had that, I don't know, neurotest. It's not IPAP shouldn't cause a thyroid storm, but like really bad, like pneumonia, infection, again, trauma, that stressful event or illness can cause it. Thyroid surgery, iodine. If you are on, say, PTU, and you just stop taking your meds, either because you're older and you forget, you don't have insurance or follow-up, you watch it, for whatever reason, that can cause thyroid storm. And then every now and then, it is how someone will present with Graves, but less likely. But technically, it could be your first, I guess, presentation of Graves' disease, especially if you're pregnant. Precipitation, all those factors kind of make sense, right? A disruption. And now, remember, we have our metabolic knob, and we're turning it up, but we're going way up, right? We definitely have cardiac arrhythmias, right? Heart failure, tachy, AFib, shock. We do not feel good. We're sweating, significant tremors. Dehydration is a really big thing for these people, and high fever. So if I have a high fever, I'm tremor and restless, it kind of makes, then you add delirium and agitation, like this is a sick patient, right? This is a scary patient. There is this Birch-Ortowski score that they may or may not use in the ER, but you basically, it's essentially if you have GI symptoms, the vomiting and diarrhea, and a super high temp, plus cardiovascular disease, chest, congestive heart failure, and a history of Graves, you tally up those points and it can kind of tell you if thyroid storm crisis is imminent. So I don't think we calculate or do any of that, but that does exist. So we have thyroid storm. What should we do? Crazy amount of thyroid hormone. What should we do first? Yeah, we need to block the synthesis of T4 and T3. So PTU are methimazole, so our anti-thyroid meds. So PTU, and I said before, it works for pregnancy, but it's kind of annoying because you have to dose it 3 or 4 times a day. But for this, we like it because it blocks the synthesis of T4 and T3. Where methimazole only does the synthesis of T4. But either way, all you need to know, we need to throw anti-thyroid meds at it first. Okay? We can also give them propranolol, but this is an emergency state, so we need to give them IV propranolol, right? We want to compound the cardiac stuff and signs and symptoms management. I talked to Major Heart, and I think we teach the same thing, but you wait to give iodide till after you put the anti-thyroid drugs on board, right? Why do you think? We don't want the iodine to stimulate more activity. The thyroid's already super active. So we need to calm that synthesis down before we give that, okay? So I don't like to do the give this, then this, give this, especially in an emergency situation. Because like with DKA, all the things are happening at the same time. But this one's important. You have to wait to give that, okay? Big old yellow arrow. What do you do first? Stop the synthesis, right? And then you can give steroids too to help as well. Definitive treatment, we're going to ablate this person. Because what is the definitive treatment for Graves in the United States anyway? An ablation, right? So for whatever reason, that didn't happen, now we need to do that. Or potentially surgery. And these guys are, it makes sense why they need to be in the ICU. Yeah, these are sick. And we're doing IV propranolol and iodide, like no, that's, they get admitted. because the mortality is not super great for them. Okay. So mid to ICU, endo's involved. They're really hot, so cooling, like temperature regulation, respiratory and cardiac support are really important. And then again, definitive treatment is ablation or surgery. No more anti-thyroid meds. We need to knock this out. All right. So the opposite, where we have super low T4 and T3, is your myxedemia crisis, right? Also life-threatening, rare complication, but it's a really big deal. And precipitating factors, these also make sense, right? So if you have, it's typically a little old lady, 80% of the time it's a woman, a little old lady who just stopped taking her pills. Maybe she lives at home and she has some dementia and she forgets, right? Dementia, that's tomorrow. And she forgets her meds. Or again, maybe she loses access to those prescriptions for whatever reason. They're at risk for the myxedemia crisis. Or an underlying infection, trauma, cold exposure is interesting. But yes, so some disruption causes this. And again, most in elderly women who've had a stroke or for sure stopped their meds. That's the primary. Okay, does this look very different than the thyroid storm? A little bit, right? So we have hypothermia, hypoventilation, hyponatremia, all these hypos, hypotensive. They're impaired cognition, just like thyroid storm. Thyroid storm is that like delirium, agitation. But these people are confused and impaired, but in that low hypo state. This is where you'll see the puffy eyes and puffy face. What does frowsy hair mean? Last class there was a guy, he knew it like that. So yeah, which is not, it's not a term I use, but untidy or unkept. So there you go, word of the day, frowsy hair. They're of apathetic appearance, and then they can also have lymphedema. But this is an elderly woman, definitely probably has a history of hypothyroidism, potentially stopped her meds, and she has the puffy face, potentially yellowing of the skin, and then the frowsy, kind of like dull appearances. Maybe too, like you have the woman who's like in the nursing home and is supposed to take her meds, but decides not to. You know, you get a little ornery when you get older. Mortality rate is high, just like thyroid storm. So if you have, and then just FYI, they're sensitive to opioids, so you have to be cautious when you give opioids because of the hypo, right? Like hypotension, hyponatremia, hypoventilation, all of that. And so the treatment should make sense, right? We want to monitor these people with IV levothyroxine. We're not just going to write a prescription and say, see you back in 6 to 8 weeks. We'll see if this works. No, we need IV levothyroxine. This is an emergency, supportive care. And then we have to deal with the hypertension, hyponatremia, hypoglycemia. We have to deal with all those hypos. So they're going to hang out there. And if an infection caused it or trauma, we're going to treat those things. Okay. Questions about that? Okay. So that's it for the material. We're going through the cases. And if you guys are good pushing, instead of 10 minutes, we might go to 15 more minutes, so 5 minutes over, and then we'll be done. Yeah? Okay. Or you want a break? For 10? Yeah, no. Okay. Yeah. Like, okay. All right. Clinic. See what you guys remember besides migraines and Alzheimer's. Okay. Thyroid Stewart. He's a she is a 35-year-old female who has palpitations for 3 to 4 weeks. What? Do you think we're hyper or hypo? That's where my brain goes to. Let's see. She also complains of fatigue, heat intolerance, nervousness, shakiness, and irritability. Pause real quick. Do you guys see how I can't just say palpitations on the test, right? This is endo. I have to give you a cluster of things. Okay. Her hair and skin are more oily than normal, increase in frequency of bowel movements, and she had a mild upper respiratory tract infection a few weeks ago. It's better. She feels fine now. Family history, mom takes levothyroxine for some kind of thyroid disease. Does this change anything? Are we still thinking hyper?
Yeah.
Okay, and with hyper we have like our Graves or our thyroiditis or our toxic multinodal or that. Okay, so our differential might be expanding based on these little things, but let's keep going. This just, sure, that helps you. All right, so we get vitals, we get physical exam. Vitals, what do you guys think? Blood pressure, elevated, pulse, just a little tacky. No fever at the moment, respiration is on the high side. Okay, let's keep going. Thyroid gland, diffusely tender, but doesn't appear enlarged. No erythema, okay, or fluctuates, right? That rules out what? Potentially, the bacterial. Yeah, bad infectious bacterial. ENT, lung, cardiac, everything else is fine. What should we do next? Labs. What labs should we do on her? T4, maybe a T3 because she's hyperthyroid. If we can get that, but for sure TSH. I like it. Hyper or hypo? Okay, so we know this, overactive, we get that. Okay. Now what? So all we have is our TSHN, T4, should we get maybe some more labs? Yeah, and we're, let's get these labs. So T3, let's get an antibody panel, right? Because that can kind of, we know something's up, but that'll help us if it's Graves or some something like that. ESR, for sure. Radioactive iodine scan and an endocrine salt started. The minute I have a hyperthyroid patient, I'm going to get endo on board because it takes a while. But endo wants you to do all the labs first. You guys okay with that? Okay. So we get the scan first. I don't know how that happens. They're faster than the lab. And we have uptake of 1%. Normal is that. So the result is low radioactive iodine uptake. So I'm kind of thinking, could that be Graves, do you think, or the thyroiditis? Thyroid, right? Because Graves is the party, even on the scan, and not so much here, right? Most likely diagnosis? Thyroiditis, the viral cause, right? So the painful subacute, because are Graves painful? No. Then Graves you could have a URI before. But again, there's all the pieces together are pointing towards the subacute. Painful subacute thyroiditis, likely from some virus. Additional tests, so we're waiting on our T3, our thyroid antibodies. Do we need to do anything else? Well, we got our ESR back, it's high. Antibodies are benign. And let's just say T3 is mildly elevated. I don't know where that went off. That's my bad. I'll add her in there, or it in there. How do we treat this? NSAIDs, right? I've been taking approximately 500 milligrams for the last 3 days. I'm in pain. Corticosteroids. Yes, awesome. Oh, but I'm shaky. Will that help with my shakiness and my nervousness? Yeah. Yeah, beta blocker. Propranolol, right? Okay. Perfect. Don't worry about the doses. Man, that's a high dose of propranolol. Anyway, it's okay. We want to see her back in a month and monitor the TSH. You guys feel okay with that? Now, all come together. We can put it to the clinic. Okay. All right. Next, we have metabolism, another female, because we're in thyroid realm, and she presents for a sports physical. Feels great, no concerns. Wait a minute. All right. Oh, past medical history of radiation therapy at age 6 for an enlarged tonsils in her hometown of Thailand. Meds none. Vital signs are stable. Thyroid. We have a firm fixed nodule on the right side, and lymph nodes are enlarged on the anterior cervical side. Yeah. Before I biopsy, what do I do? Labs. Which labs? TSH minimum, yeah. And then what imaging? Well, the lab will kind of tell me what imaging to do, right? So let's do. So we get our labs, and with either one, we would do an ultrasound. So if the TSH is normal, we're going to do an ultrasound for the nodule. If the TSH shows this, which is normal, If the TSH shows hypo, we're going to get an ultrasound. If the TSH shows hyper, we're going to get an ultrasound. What else do I get if they're hyper though? The scan. Okay, so we do the TSH and it is normal, but the ultrasound shows a fluid-filled complex cyst. Are we done? Refer to who? Nope, before endo. We can send them to endo, but what else? How do I find out what that complex cyst is? FNA biopsy, yeah, which you already alluded to. On a 10th, I'm going to give you more than complex cyst. But again, this is complex. Think of like that's not benign or basic, it's complex. So, no, we're not done. Let's do an FNA biopsy to see if she has cancer. And remember, she also had lymph nodes, right? She had these enlarged lymph nodes, and she has a history of radiation. So we send her for the FNA biopsy. We can put that into a consult in just to get it started. Anticipate that we're going to have to track track the nodule with an ultrasound, and then giving patient education. This person for sure is suspicious, right? You know, yeah, suspicious. Hopefully for papillary cancer. I mean, I don't hope she has cancer, but if she has one, papillary cancer. How do we treat someone with papillary thyroid cancer? Surgery, right? Yeah, we surgery and then it potentially ablated after, but surgery is a definitive treatment, and then what happens after? We give a levothyroxine, but we really want to suppress that TSH, right? Okay, questions? That's it for the thyroid. Tomorrow we have, what do we have?